Today I will be sharing some of my experiences during my overseas training in the UK and a few therapeutic advances that I came across during that period. So the objectives of this presentation would be to share some key experiences from UK neurology training and compare the practices between UK and Sri Lanka and discuss some of the recent advances in neurology and identify lessons applicable to Sri Lankan practice. So this will be the content of this presentation. I will be speaking about the training setting and my experience first and clinical practices that interest me and a few advances in neurology, mainly neurology, migraine, epilepsy, and Parkinson's disease, and some of the lessons of personal reflections. So I worked as a senior clinical fellow in neurology in Queen's Hospital, Romford, from October 2024 to February 2026, roughly 15 months. So the neurology service there consists of acute neurology services, mainly we have the on-call system where we have to attend the emergency department patients and also the referral system. And we have separate neurology wards and neurosurgical wards, stroke wards. We have a unit called Plan Investigation Unit where patients come in as day cases for investigations like lumbar punctures. They also undergo certain procedures like great occipital nerve blocks, things like that. And then we have the registrar-led rapid access neurology clinic because, as you all know, the waiting period to see a neurologist in UK ranges between 3 months to 1 year. The average duration would be like 6 months. So the patients who need early clinical attention, most of these patients will be triaged into this rapid access neurology clinic where we, either a senior clinical fellow or a registrar, will see the patient, and this will be under the supervision of a consultant. And there are other general neurology clinics and subspecialty clinics. There were so many subspecialty clinics in movement disorder, neuroimmunology clinics, headache clinics, epilepsy clinic, functional neurological disorders, neuromuscular disorders, motor neuron disease, cognitive neurology clinics, and neurooperative clinics, to name a few. And there are many multidisciplinary team meetings that are happening like either weekly or monthly. For example, neuroradiology meetings, CS vision DTs, muscle biopsy, nerve biopsy, DTs. So as I said, the structure of the neurology service in our trust, we have dedicated acute neurology services, clinics, and then the neurology team consists of many people in not just neurologists. We have specialist nurses, the CNS, so nurse specialists like epilepsy nurse specialists, multiple sclerosis nurse specialists, disorder nurse specialists to help the neurologists. And we have the neuroelectrophysiologists and physiotherapists, occupational therapists, speech therapists, and also clinical pharmacists. So neurologically,
how many neurologists were there?
12 neurologists.
How many clinical pharmacists?
We have one main clinical pharmacist for
and that is dedicated to your
sciences and 3 or 4 assistant clinical pharmacists.
How many beds do you have?
So we have 2 wards, madam, shared by neurology and neurosurgery. So neurology, we have like 50 dedicated neurology beds, but sometimes we have more patients, sometimes neurosurgery have patients like
on average about 20.
Yes. So the neurology care in the UK is more team-based rather than physician-centered compared to Sri Lanka. Whereas in Sri Lanka, neurology practice, what I felt was that it is highly consultant dependent. But in the UK, it was heavily influenced by multidisciplinary teams, and there was rigorous adherence to NICE guidelines and trust protocols. And about stroke, in the UK, stroke medicine and neurology are considered distinct subspecialties. So basically, we were not involved much in the stroke management. And to be honest, as neurologists, we are supposed to refer patients to stroke team if one of our patients develops. We are not supposed to be the stroke. Yes. Consultation there. So most of the stroke physicians come from either geriatric medicine or internal medicine. Some of them are neurologists.
And they do PhDs also. I have a friend who did actually general medicine and she did a PhD in stroke area. She's a stroke.
So we compare some of the aspects in neurology services. Neurology workforce in UK, there are more subspecialists rather than general neurologists. And in Sri Lanka, we have very limited subspecialists. Here mostly they are general neurologists. And MDT involvement is extensive in the UK. In Sri Lanka, it is limited. And if you consider investigations, in UK you have so many investigations available and rapid access, but in Sri Lanka we have limited investigations and often delayed, and we tend to rely more on our clinical judgment.
I thought rapid access is more here to get an MRI done. It's much easier here than getting an MRI done in okay.
Here I think it's just 10 years, but in other areas, for example, MRI.
In the private sector, you can immediately get an MRI done.
I think this is like once you get into neurology and if it's needed, you can get it done. That's what you mean.
If needed, you can get it done within a few hours or maximum 2-3 days. But when it comes to more sophisticated investigations like specialized antibody testing and all, they don't have facilities to do that. So there are PET scans and all.
When you say more subspecialty, what are the subspecialties? Are they separate board certifications? Or is the board certification neurology?
It's board certification in neurology,
Right.
but for example, you have neuroimmunologists with special interest in neurology. So they hardly see patients with headache, epilepsy, and all that. They are more dedicated.
Cross specialties.
Yes.
Muscular disorders and myopathy. There's only
Neuron and neuromuscular.
All of this is very difficult there. UK to begin with. So about at least 6 months.
Average.
ඒක වෙලා තියෙන්නේ ඕක හින්දා. Where they don't see other patients, they are focused on their supra specialty. Yeah, you can't, access a general neurologist.
No, I think because that has to go to the GP, It's a GP. So you have to always go to the GP, and only if the GP determines that you need any neurology referral, then they will.
එතකොට you said you have 20 odd, neurologists. ඒකෙන් කී දෙනෙක් generalist? The others will have special interest, so they won't see the general patients.
We did not have but they do
So they Netflix can
they do. But only some of them. Some of the neurologists were highly specialized, but they do on calls and they see when they get a patient, they would usually refer to the relevant subspecialist.
How is the overall general initial care for the neurology patient, like with all this waiting time and then going to various people to reach the person? on the way, aren't there issues that you experience?
In clinic system, or in the
Where the system is working over there, in case somebody gets.
referrals come from the GP, and the consultants will triage the referrals, and depending on, say, if the referral looks like, say, it was about a headache, so the triaging consultant will refer the patient to headache clinic. Like that.
Personally, but we still. So the waiting time meet a neurologist in many cases. The patient actually sees the neurologist 6 months later, is it?
It's 3 months, 3 months to 1 year, I would say. Usually 6 months. But if they feel that this patient has to be seen immediately, of course, patient will be referred to the rapid access clinic.
That's why they're the rapid access clinics. Like, for example, if you suspect a TIA or something like that, then I think they are referred to the rapid access clinics, no?
TIA, stroke.
Stroke,
But say, we suspect something like a multiple sclerosis with the relapse or something. Sometimes we see patients the next day itself. We have rapid access clinic, one rapid access clinic once a week, but the waiting period is like 1 week to 3 weeks. So
Rapid access.
Ultra rapid access are more than ultra rapid access.
Yes, that's A&E. That's A&E. But A&E also, there's a wait time of about 10 hours, I think.
Yes.
48 hours.
40, yeah.
When we see the patient,
Yeah.
patient says, "Doctor, I've been waiting here, sitting in this chair for 48 hours."
Yes. That's why they really dread going into A&E.
Oh.
එන්නකර මේට ඇවිල්ලා මේ කරගන්න
Springs. But I know that in Australia now, because this waiting time and all must be the reason, anybody that goes into the A&E would end up with the LP if there's an headache. Because they are so scared of this patient.
Yeah.
Yes, my mother had a fracture in Australia. She had a cordis fracture. So went to the same hospital that my sister's working.
Yeah.
But then they still had waited 7 hours to be seen by the orthopedic team and still the fracture managed. And one of my friends, a consultant, had a bleed at the UK. Her blood pressure was low. At the same hospital, she was seated in the A&E because she had said coming out of the ambulance, when they asked, "Can you sit?" She had said, "Okay." So how the triage is the once she's tachycardic, blood pressure, she's pale. Next time, don't be stupid. Just say that you feel faintish.
You were saying LP, Devindi nearly had LP after. Yes, on the first day she was having, I think because it was too cold. So she was having a little bit of, and then they were going to do LP. The registrar was coming, also a pediatric person was coming and asking me consent to do a LP. I said, no way. She was born, without any problem. So otherwise they would have done any other patient, they would have done LP unnecessarily. So
That's like that. If a patient comes with fever and headache or confusion and fever, something like that, A&E doctor will start Ketrazole and acyclovir. Then they refer to us, and most of the neurologists are scared to stop Ketrazole and acyclovir without an LP. So the patient will anyway have LP. Only the very senior, very confident neurologist would say this is not meningitis, just stop. Otherwise,
they go according to all these guidelines.
guidelines.
And checklists and
So there were good things and bad things, but I'm going to focus on the clinical practices that interest me. So one thing I was really impressed about was the detailed neurological examination culture that they have. All the trainees, all the consultants, neurologists, they would examine the patient head to toe, full neurological examination, at least the relevant neurological examination, bedside in the clinic. So that was something that really interests me, because when we see the consultants doing that, we get to the habit of doing that ourselves. And although they have all the investigations at their disposal, they still tend to do a full neurological examination, come to clinical diagnosis, and plan their investigations accordingly. And subspecialty clinics, in Sri Lanka, I think the only real subspecialty clinic that we have is the epilepsy clinic. We have NHS, and other than that, although several units have movement disorder clinics and stroke neurovascular clinic, they are not really true subspecialty clinics, because we see a lot of other patients also, even in the movement disorder clinic. So having dedicated subspecialty clinics was something I thought that was useful, because because those patients tend to get the best care, because not just the neurologists, they are usually the nurse, subspecialty nurse specialist is also present in the clinic, and and sometimes the occupational therapist, physiotherapist, or social service worker, all are present in the clinic. So I think that was a good practice that I observed in the UK, and their documentation standards. So it was a complete electronic system, but even the smallest thing, they tend to document, and it's easier when we go back, and if we can't find, if you want to see why this drug was prescribed to this patient, if you go back, you can find everything, what happened on that particular day, why that particular drug was started on the patient. So the documentation standards are very good, something we have to improve. And the culture of audits and quality improvement, something that they really focus on. Every time, like at any given point, there will be like 5-6 audits going on, and they encourage writing case reports, doing research, something I noticed. Then the entities, of course, it has its pros and cons. One thing I would say, because they tend to have so many entities, sometimes patient care tends to get delayed, because if you want to start a medication, say rituximab, sometimes clinicians tend to, like, they don't
take that
take
call
the
alone.
decision, they wait for the MTT results. Sometimes the decision will be delayed by 1 or 2 weeks, just because the MTT is getting delayed or something like that. So here, if the consultant decides that we need to start this medication to this patient, immediately next day the medication will start. There's a delay, but in a way, it's a good thing, because you get so many inputs, not just from your team. Sometimes we refer the patients to Queen's Fair MDT, things like that. So you get a lot of expert opinion. So in a way, it improves the patient care.
ඒ වගේ high cost medicines use කරන්න approval ඕන.
For example, for IVIG, it's really difficult for us to start unless there's clear indication.
HOs, registrars,
Everybody starts AS.
start IVIG.
IVIG for rheumatology, madam, it's difficult to get, but sometimes we have to. And at Royal Free, the rheumatology team is kind of like, and they work like us a little bit, clinical lead and all that, little bit like us. And the clinical pharmacist that we had, the senior clinical pharmacist, is also sort of take it in. So sometimes we have like labeled them as myositis when there's no myositis. And the patient goes somewhere else for something because we are the reference.
මේ IVIG කියලා දෙන්නේ කෙහෙලියගේ IVIG.
Prescribe the first dose.
ඊට පස්සේ approval කරනවා.
In emergency case, you can give this dose, but after that, you need to give it.
But the approvals are not difficult, man. Approvals are not like you need to do the documentation and you need to follow up. But there's a system like for emergency these things. You can get the electronic these things, but then when they have the meeting, you have to be there to justify your this thing and process.
Once there was a patient with remember I think stiff person some form of an autoimmune disorder. So in that so the panel approval will only be given to autoimmune form of that disorder, not to the paraneoplastic. So if there's any evidence to say that this could be paraneoplastic, they would approve. So one of our patients, we couldn't get the approval because we mentioned that this antibody was positive. So, and the committee didn't have a neurologist. So it was very difficult to explain to them that this still could be an autoimmune thing. They didn't give the approval. So, and sometimes it's very tricky. And the use of clinical protocols, so they tend to adhere to rigorously adhere to NICE guidelines and trust guidelines, and they always go for evidence-based pathways. For example, there are health management pathways, epilepsy guidelines, MS treatment algorithms. So this makes sure that every patient gets a standardized care and there's reduction of practice variability among the.
And another good thing about it, this is instilled in medical students from the student days, and they are questioned on all these, so there is no ambiguity in the answers. Sometimes when we discuss questions, we have ambiguity. Okay, what is the right answer? There's no ambiguity because it's all based on NICE guidelines. What is there in NICE guidelines is the correct answer. But then here, because there can be some, we might think this may be the correct one and so on. There's nothing. So I think that's another very good thing. So probably something that we also should go by is recommend here some guidelines, at least for the students, so that they will be then familiar with the guidelines. At least we have some local guidelines, no? So,
NHS trust
and I said there are separate trust guidelines, right?
But they are based on
the NICE.
Yeah, they have to be. Yeah.
Because sometimes some trusts don't have certain medications, so they. And the role of multidisciplinary care that I already explained. For example, if you take a patient with Parkinson's disease, so many people will be involved in the management, not just the neurologist. There will be Parkinson's disease nurse specialists, various therapists, social service worker, etc. And this will improve the quality of life of the patient and lead to better long-term solution. And another thing I noticed was the differences in prescribing culture in the UK. For example, in UK, we have a lot of support from the pharmacists when it comes to prescribing. If we are not sure about a drug interaction or anything, we go to the pharmacist and they will check everything and tell us. And the BNF, so every doctor will have the access, either in their phone, app or online. They will not prescribe without checking the BNF, usually the dose and everything. But in Sri Lanka, it's mostly doctor dependent. And drug interaction checks are routine in the UK, and medication reconciliation is more systematic. Documentation is very structured, and there will be multiple safety checks because of the electronic prescribing section, and the involvement of the clinical pharmacies. This was what we were discussing, access to high cost drugs. So there will be specialized NHS funding pathways and very strict eligibility criteria to prescribe high cost drugs. And most of these drugs need specialist approval or panel approval. And there will be involvement of the clinical pharmacist in drug approval, monitoring, and assessing cost effectiveness. Another thing I was impressed about UK was their adherence to antibiotic stewardship. It is a national priority in the NHS and it aims at reducing antimicrobial resistance, improving patient outcomes, and ensuring cost-effective use. The core principles they have is to choose the right drug in right dose, prescribe for right duration, for right indication. And they have local hospital antibiotic guidelines as well as NICE guidelines. They are integrated into hospital systems and they are very easily accessible during ward rounds. And usually doctors don't prescribe out of these guidelines. For example, if we say patient comes with community-acquired pneumonia, the slide would be amoxicillin. We don't go for amoxicillin pocket tracts or no, to be honest. During that 1.5 years, I have only seen meropenem prescribed just once. I have seen so many patients who were prescribed amoxicillin getting better without anything else. So the antibiotic resistance is very low and the involvement of clinical pharmacists. Antimicrobials.
Stewardship. Thank you. Thank you. පළවෙනි ගානත් අනිත් එක දාන්න. නෑ එතන stewardship කියන්නේ මොකද්ද නේ ඒකේ what do you mean by stewardship?
It's a buzzword now. I'm trying to use stewardship.
No, yeah, now when you say I have heard of this, but what is really implied in that stewardship? Leadership, you go with that again.
There are 7 steps in antibiotic stewardship. There's some.
Okay. Yeah, leadership, that's a
Leadership, monitoring, yes, right selection.
And clinical pharmacists, microbiologists are actively involved in making therapeutic decisions, changing antibiotic duration, route and changing antimicrobial. So that is also a very big thing. And of course, about documentation about antibiotics. For every antibiotics, indication should be documented. Duration should be reviewed. So once an antibiotic is prescribed, we have to review the indication, duration, and of the antibiotic after 48 to 72 hours. Otherwise, system will not allow us to prescribe the antibiotic. So this is what I have already explained. So I will move to the therapeutic advances that I came across in neurology. So firstly, I will talk about the advances I noticed in neurology. Especially in multiple sclerosis. We know that there's no cure for multiple sclerosis, but during the last few years or maybe a decade, disease-modifying therapies newer disease-modifying therapies have been introduced, and we see that the patients that we diagnose nowadays do much better in terms of disability compared to the patients who were diagnosed 20, 30 years ago. This is because of the advances in TFTs, because they slow the disease progression, reduce relapses, and reduce the disability in patients with multiple sclerosis. Historically, MS treatment used to be escalation strategy, where patients were initiated on medications that are low intensity, but had fewer risks and fewer adverse, like a safer adverse effect profile. But now the new evidence suggests that early use of high efficacy DNTs improve the outcomes in multiple sclerosis. So it leads to better long-term outcomes and reduce long-term disability. So now it is encouraged that we start high efficacy treatment early in the course of disease, soon after the diagnosis. So in Sri Lanka, we only have a few disease-modifying therapies to treat multiple sclerosis. We have interferon beta, and many clinicians use rituximab, but rituximab is not an licensed drug to treat multiple sclerosis in UK because it's one of a broad spectrum drug. So the side effects are more compared to the specific drugs that they use in the UK. So we have low.
Fingolimab was used here, no? Fingolimab?
Yes, in some patients. And we also have mitocentrone. I think they order it specifically for certain patients. We have that, but we don't have other B-cell therapies that they use in the UK. For example, they use ocrelizumab now. It's anti-CD20 monoclonal antibody. That is the medication that they use mostly because it is licensed to treat both relapsing multiple sclerosis and primary progressive multiple sclerosis. That is the only medication that is licensed in primary progressive multiple sclerosis. And they have other newer monoclonal antibodies against B cells like ofatumumab and ublituximab. Ublituximab, again, it is the latest drug to be licensed to treat relapsing multiple sclerosis, licensed to 2023. I think they use it a lot nowadays. And now they have this oral medication called Caribbean. Again, it is given as courses, short courses, 1 year apart. Another newer medication, and they have suponinon.
Actually, ocrelizumab, they may be having generics now because it has been there now for a long time now. So, generic versions are there now.
Yes.
The biosimilars.
Biosimilars are there. Now they are using biosimilars. We recently started using.
I think we also registered ocrelizumab before. When we have registered products, I'm not sure. But I remember, as if we just registered here. But definitely, biosimilars we should be getting down.
Rituximab is also CD20, CD27, like what Seneca Pandasena is also saying is for MS. Rituximab really does work. Yeah, I don't know if it work.
We use it's
Much cheaper, so
it's cheaper. It works.
What is the difference between ocrelizumab and rituximab? Because rituximab is also anti-CD20.
ocrelizumab is a DNA, some other mechanism, it's a monoclonal antibody. Oblituzumab is anti-CD20.
Sorry?
That oblituzumab, the third one.
CD20. That's what she's saying.
But we were talking about this. It's like a different antigenic pathway or something like that. It's not the exact.
It's the same as rituximab, but there must be similarities. That's why it is. It is working. Yeah.
And even in progressive, although it is not being licensed, we use for progressive forms of multiple sclerosis also with some evidence. You can see this is the trend of prescribing DMTs, first time DMTs. So you can see ocrelizumab is the most prescribed medication in the UK. And after oblituzumab was introduced in 2023, and that is also being prescribed. And other drugs like I never saw a patient who was on low efficacy medications, for example, with beta interferon, although it was there, they hardly use it anymore. They tend to switch between these high efficacy medications nowadays, and patients are doing very well.
So might as well we also should change to us that because we are spending I think nearly 2 million for beta interferon, right? So per patient.
Efficacy is about 30%.
Sorry?
Efficacy is about 30%.
Yeah, so might as well, use something like that generic version of ocrelizumab, which may be, better, and maybe even rituximab rather than spending so much on.
I think that is ocrelizumab is a fully human. It's chimeric.
That's chimeric. Okay. Right.
And there are other emerging targets that they are trialing, for example, pre-myelinating therapies, BTK inhibitors, and other combination immune blockers. So,
Excuse me, I have the meeting, excuse me.
I was involved in this trial called Octopus trial. It's a multi-arm, multi-phase trial, UK-based trial that focuses on disease-modifying therapies for progressive types of multiple sclerosis. So they were trying metformin and alpha-lipoic acid in patients with progressive forms of multiple sclerosis, and they are in phase 2-3, combined phase 2-3 right now, and according to the unofficial sources, metformin has been shown to be promising in treating progressive forms of multiple sclerosis. To advances in migraine treatment. Nowadays there's a lot of focus on this calcitonin gene-related peptide, which is implicated at the physiology of migraine. It is a neuropeptide released during acute migraine attacks that transmits pain signals, causes inflammation, and dilates blood vessels. So, over the past few years, there have been CGRP or calcitonin gene-related peptide targeted therapies in form of monoclonal antibodies and another oral medication class of group of medications called GPAs that block this pathway, providing effective and targeted prevention and also acute attack treatment for episodic migraine and chronic migraines. So the first molecule to show potential to block these CGRP receptors was called GPAs. They don't cause delayed vasoconstriction, which is an advantage compared to the triptans because patients with migraine tend to have cardiovascular risk factors in them. So one advantage over of GPAs or triptans is that they don't cause vasoconstriction, and then they are used mainly for acute attack treatment, but some of them have been used in preventive treatment also. And then there are monoclonal antibodies against CGRP receptor and the CGRP molecule itself. And these monoclonal antibodies have been used for prophylaxis of migraine. And about half of these patients receiving these medications experience a 50% reduction in migraine days, which is the aim, the target in treating chronic migraine and both chronic and episodic migraine. So they have strict criteria to select patients for these medications. So the preventatives, the monoclonal antibodies, are indicated for adults with 4 or more days, 4 or more attacks per month, who have failed at least 3 prior preventative treatments, And also GPAS, they are recommended for both episodic and chronic migraines, both in acute attack treatment and rimegepant has been used for as a preventative as well. Again, they have strict criteria, and only a neurologist can prescribe initiate these medications. And treatment should be discontinued if migraine frequency does not reduce by 50% for episodic migraine or by 30% for chronic migraine after 3 months of use. I came across a few new medications that were recently introduced. Examples include esricarbazepine, sonazepam, brivaracetam, cenobamate, and phenelphonal. They also use lacosamide and levetiracetam inclusively.
In treating what?
Increasingly, in treating epilepsy.
Okay.
So, esricarbazepine is a sodium channel blocker, similar to carbazepine and oxcarbazepine. The tolerability and pharmacokinetic profile is similar to that of oxcarbazepine and carbazepine. But the advantage of esricarbazepine is that this is a once-a-day medication. It has a long half-life and it can be given once a day, so it improves the compliance. There are no head-to-head comparisons between this and other two medications, but it has been suggested that some of the patients who do not respond to carbazepine and oxcarb tend to respond to esricarbazepine. Then phenelphonal is the first drug that interacts with glutamate receptors. It has been licensed to treat focal epilepsy, but some epileptologists use these as second or and antiepileptic in treatment of generalized epilepsy as well. This drug doesn't have pharmacokinetic interactions with other antiepileptics, and it has a very prolonged half-life, so it also can be given as a once-a-day medication. Then there's sonazepam, again thought to be a broad-spectrum anti-seizure medication which treats focal epilepsy, generalized epilepsy, and also myoclonic epilepsy. And again, it has a long half-life, so it can be given once a day. Then cenobamate, another very useful drug that I came across. This is approved for the treatment of focal epilepsy mainly, but again, some clinicians use this as second or third line in refractory generalized epilepsy as well. In a very high efficacy treatment, some patients who do not respond to 2, 3, 4 antiepileptics tend to respond very well to cenobamate. Then they have brivaracetam, which belongs to the same class as levetiracetam, same mechanism of action, but it has less neuropsychiatric adverse effects. Although we tend to prescribe levetiracetam a lot, we tend to ignore the fact that it has a lot of neuropsychiatric side effects. Especially patients with psychiatric comorbidities, it's better to avoid levetiracetam because these side effects are very common than we realize.
Neuropsychiatric
like irritability, impulsive behavior. Sometimes it tends to worsen the mood disorders like depression, mainly impulsive behavior and irritability. And especially in very elderly patients, these manifestations tend to be. And brivaracetam is thought to have less neuropsychiatric adverse effects compared to levetiracetam. And but it is controversial because even though we tend to switch patients who are on levetiracetam with brivaracetam, hoping there would be less neuropsychiatric manifestations. What we have noticed is that it also has these effects, and the efficacy-wise, levetiracetam is better than this medication. But the advantage is that you can switch it overnight. So if a patient is on levetiracetam, you can immediately switch it to brivaracetam without having to taper off levetiracetam.
But what I'm getting forgetful now that you talked about multiple sclerosis, then ඒගොල්ලන්ට ACTH දෙන්නෙම නැද්ද?
ACTH?
Nah, when we were students and when I worked in UK, the first line probably treatment was ACTH. Multiple sclerosis happened. MS. Then
And myoclonic epilepsy that is ACTH.
ඒක ඉතින් පරණේකනේ මේ
Yes.
corticotrophin. Yes.
Multiple
No,
sclerosis?
no.
Another thing I wanted to highlight was this pregnancy prevention program, sodium valproate. I wouldn't call it a therapeutic advance because this is a highly debated topic, and most neurologists don't agree with this because nowadays there are so many restrictions to initiating sodium valproate because it is a highly therapeutic drug, and exposure of an unborn child to valproate in utero is associated with very high risk of congenital malformations. The risk is about 11%, and the risk of neurodevelopmental disorders is about 30 to 40%, and it increases the risk of autism spectrum disorder by about threefold. So, the available evidence does not support specific at-risk gestational period. So they think exposure to valproate at any point pregnancy can be a risk to the unborn child. So, therefore, if a patient has to be started on sodium valproate, they recommend that the patient is on at least one highly effective method of contraception, preferably use independent method like intrauterine device or implant, or two complementary forms of contraception, one being the marriage barrier method. And if a patient becomes pregnant while on valproate, they encourage that the patient be immediately referred to a specialist neurologist to consider alternative treatment options. So, and in males, valproate can cause male infertility, and also it is thought to have toxic effects on testes. And also in men who take valproate in the 3 months before conception, about 5 children in every 100 may have neurodevelopmental disorders. So male patients aged under 55 years who are being started on valproate are now required to complete a risk acknowledgement form from with a healthcare professional. So as a precaution, male patients who are on valproate who are planning to start a family next year should talk to their healthcare professional, and if possible, treatment should be changed. And men are advised not to donate sperm during valproate treatment and for 3 months after stopping valproate. And it is recommended that male patients use effective contraception throughout valproate treatment period, and for 3 months after stopping valproate to allow one complete sperm cycle not exposed to valproate. So in January 2024, they introduced new prescribing practices for valproate. There are new additional restrictions for prescribing valproate. So every female female and male patients under 55 years of age should not be started on valproate without two specialists signing off prescription. And women who are already taking valproate will need to sign off from two specialists to continue. And men already taking valproate will need sign off from two specialists to continue later next year. So, so the new measures mean that no one under age of 55, both men and women, should be started on valproate unless two specialists independently agree and document that there is no other safe and effective medication, or that there are compelling reasons why the reproductive risks linked to valproate do not apply. So valproate is
sorry. ඔය කියන විදිහට මේවා නිකන් මේ කොහොම වසවර්ගයක් වගේ නේ කියන්නේ. මෙහෙනම් මේ use it by the ton like, you know.
very effective medication, highly efficacious medication compared to other antiepileptic drugs, and now we really can't prescribe valproate anymore. So it's
ලංකාවේ නැහැ නේ.
not here, madam, here. The UK, so even the neurologists are very disappointed with those new regulations because some patients, it's difficult to especially in generalized epilepsies, it's very difficult to treat epilepsy without valproate, and now they can't prescribe valproate without all these.
අර මොනවද මේ ලියාගෙන මේක මොකන්ද? ඊට වැඩිය දරනවා කියන්නේ. Okay, go ahead. I disturbed you. I'm sorry, I disturbed you.
Same for topiramate. But topiramate, of course, we don't use much in epilepsy. But if you have a patient with migraine and idiopathic intracranial hypertension, topiramate is a very good drug. And most of these patients are young females. Now we can't prescribe topiramate.
Also, like below 55, still there are maybe people who have completed the family and like the risk of pregnancy and all. You have
Yes,
to
in that case, two specialists have to agree and they have to sign and the formal procedure saying this patient has completed family or there are compelling indications to start treatment. Otherwise, they can't.
We need to go to sensitize our local consultants also to do this kind of thing.
It's true, madam, because there are patients, there are young people. There are young females who are on valproate for migraine prophylaxis. So for indications like this, yes, but as an antiepileptic medication, this is a bit of a hassle. So the last bit, advances in Parkinson's disease. Most of the liver treatment for Parkinson's disease are more of refinements and extensions of what we already knew. They often aim to deliver existing medications more smoothly. For example, they have continuous levodopa subcutaneous infusion now. They have apomorphine pumps and other liver dopamine agonists. So this is the continuous levodopa infusion, Produodopa, that was introduced in 2024. We had this Duodopa, which is the levodopa gel jejunal infusion, but it requires a surgical procedure for the pump to be connected to the patient. But this can be operated by the patient, changing the catheter and everything can be done by the patient because this is subcutaneous infusion. So it is a 24-hour continuous subcutaneous infusion pump for patients who have a lot of on-off fluctuations, because this is shown to reduce fluctuations by delivering a steady dose of levodopa carbidopa in the form of levodopa and carbidopa directly into the body. So advantage is that unlike levodopa, this method requires no surgical procedure or feeding to replacement.
So these first ones Do they substitute for levodopa? What's the difference in the action like? Is it same?
Action is the same, so it's
Yeah,
just
the first levodopa directly to the body ki arm. So does it get converted to levodopa?
it's converted. Levodopa, same fraction.
It's available for general use by patients. Here, even in the private sector, we don't still have.
It's very new. They introduced it in 2024, but and they have this subcutaneous apomorphine infusion also. Similar continuous device-aided therapy to reduce the off-time fluctuations. And it uses a small pump, but this has to be used only 16 hours per day and reduces off time by over 3 hours per day and allows for reduced levodopa dosage and offers a less invasive alternative to neurosurgery.
Make a subcutaneous.
This is also subcutaneous. Then they commonly use this rotigotine patch. Rotigotine is a dopamine agonist, just like clopidogrel. So this they use for patients who are unable to swallow. When a patient with Parkinson's disease comes with delirium or some form of a reduced level of consciousness or swallowing impairment, it's very difficult to. The recommendation is that if a patient can have an NG tube, we have to convert the tablets to dispersible form and give the same doses of medications. But if the patient cannot have an NG tube because of so many logistic issues that they have, unlike in Sri Lanka, here when a patient comes with reduced level of consciousness, we would straight away insert an NG tube. But they have to have lot of MDTs and all that to decide whether the patient is suitable for an NG. So in that case, we cannot discontinue dopaminergic therapy. So what we do is there are online calculators that calculate the total dose of rotigotine patch that will cover all the other dopaminergic medications the patient was on, and it is a simple patch that works for 24 hours. We just convert to rotigotine patch. But the disadvantage is that this has so many neuropsychiatric or psychiatric side effects compared to levodopa. So it's not the best medication for a patient who is already delirious because it tends to worsen hallucinations, delusions, and all these things. So whenever a patient can take orally or whenever a patient can have an NG tube, we have to change to dispersible forms of medication. So, in my point of view, there were several reasons for our practice, including the need for a structured neurological service in Sri Lanka, development of some more subspecialty clinics, strengthening multidisciplinary care, improving access to modern therapies, expanding training opportunities, strengthening role of clinical pharmacists in Sri Lanka, promoting routine use of formularies like DNA for other formularies that we have the access to, improving medication safety systems and antibiotic stewardship, improving documentation and accountability, and establishing structured funding and approval pathways for high-cost therapies. My personal reflections are, it was a great experience getting exposed to a different healthcare culture, learning from learning from excellent clinicians. And what I learned about the importance of clinical judgment despite the availability of many investigations, the value of teamwork, and I think I got an inspiration to improve neurological services locally in Sri Lanka. I something on he was supposed to be review.
Suddenly,
You
you go
came
vacation.
Vacation, madam. I have to take my annual leave.
I have to take the annual leave, so yeah.
31st March
And I need
next month.
And I have a question to you, like, so all these, there's the newer therapies that we prescribed, they still restricted use or are they just, sort of,
There is restrictions actually, they use.
I don't know, so you don't have to get prior approval, like, you know, but
They, of course, for illness therapies, you have to. There are standard medications, Parkinson medication.
right, you're fine. So you don't have to like fulfill, for example, for us who's escalating treatment of a DMARD, when if you're going for something like fibrinogen or something like, you know, you have to fulfill certain criteria to go for it.
They are
That's
for
what we
illness drugs, they
Certain
strict
criteria.
criteria. Yeah. And even for these, you have criteria, but they don't need prior approval from a panel or secretary. And even for drugs like Senovimate, they have criteria, but clinicians are free to
treat.
I have not directly related to this presentation, but from your line, the sort of currently knowing what's happening. Now, say anti-thrombolytic therapy is standard therapy for, say, myocardial infarction or heart related. Now, if you get a stroke and get is anti-thrombolytic given in Sri Lanka? Huh? And that is the results are approval. That will make a very win.
There's a risk of bleed, there's a risk of hemorrhagic transformation.
Yes.
But within, I think, 3 hours, definitely if there's a definite neurological deficit,
Yes.
that is an indication for antithrombolytics.
And what do they give?
So
Tenecteplase.
they were giving
Tenecteplase.
Tenecteplase.
Alteplase is also now switching on to more tenecteplase.
So that is generally accepted. You don't question that.
But there is a strict criteria, contraindications, so there's a checklist.
NHSL වලත් you know.
What is the level of patient involvement in prescribing these medicines or these medicines? Very high. Is there counseling and then
counseling and explaining everything, and even after everything, if the patient says no,
consenting and written
consent drugs. Yes, for example, multiple sclerosis, disease-modifying therapy, drugs like rituximab, valproate, those drugs, yes. Other ones, you don't need written consent, but of course you explain to the patient, and if the patient does not take a consenting document and
some also patients like that. Before starting treatment, what is the patient's response? They get scared and be on
Yes, I'm listening.
but I know
They know.
they are the level of
Yeah.
literacy is much advanced than Sri Lankan patients. So if you explain to them properly, they would have the to make an informed decision. But there are certain patients who would not let you prescribe, who would only focus on the side effect profile and would not let you prescribe even if it is really necessary, even not explaining and doing everything possibly can be done. But generally, the resistance complication is not an issue.
Then they want the medicine and they come asking for it.
Yes,
They might have
there are
done
patients
research
like
on
that.
their own and they might come asking for that particular one.
It also depends on how bad the condition is. When they say multiple sclerosis, they get really scared. Like when we put a label on that, certain things are very frightening, and when they go and read up, they will see all these stories, and they're very read a lot and then come.
Then another question to you is now, I mean, I know there are a lot of new things on this movement disorder, but in reality at the ground level, other than Parkinson, what sort of things do you see?
Movement disorders.
Yeah.
We see a lot of tremors and
Idiopathic tremor.
there are patients with essential tremors, dystonic tremors, and
So
function.
dystonic tremor will be some cause neither.
Usually there's a cause, but still the treatment would be symptomatic. And then there are phorias and genetic forms like Huntington disease, things like
Oh.
that.
Yeah, I think common name neither.
They are very common. But tremors are common. Tremors and Parkinson's disease.
Yeah, Parkinson, no doubt about that. අනිත් ඒවා ඉතින් මං අහන්නේ මේ ලංකාවේ දැන් ඔය අපි දකින මේ ඒ රෝග වලට වැඩිය වෙනස් ඔය මේවා තියෙනවද කියන එක තමයි that's the sort of the impression I'm trying to get from these things. දැන් ඔය වාගේ family එකේ අපේ family එකේ අර ඉන්නවා මේ ඔළුව වේවුණා නැත්නම් but I think different කියන එක now like say do you because and are there any oral therapies that are different other than you identify the cause and remove it? Are there any
They
newer
are symptomatic, not never. I mean, we have very few options, things like very non-specific options like clonazepam, benzodiazepines, then
there's something called tetrabenazine? Is it still there?
still there,
Hmm.
still. Things like that, sometimes levodopa, levetiracetam,
Yeah.
topidamate, propranolol.
Yeah.
The ones that we use here.
Yes.
They also use medication. Diseases wise, what I noticed was functional neurological disorders are extremely common in the UK compared to Sri Lanka. Here we do see patients with functional symptoms, but rarely. In the UK, it's like 70% of the cases that you see are functional. At least there's functional overlap. Maybe because of the, I don't know, because
They get the disability allowance and all the perks, benefits like I've had patients for
Fibromyalgia.
fibromyalgia,
just skin syndrome and everything. And
they get the disability badge, the parking free, housing, transport, the compensations.
Yeah, just again, this motor neuron disease also is all, they know everybody important. It looks like they're saying motor neuron disease. They can one the specific
right now, there's nothing, sir.
Ah.
Not in the UK. The only licensed medication is Riluzole. That is
Sorry?
Riluzole.
Rhinozole.
Riluzole, but the effect is that they prolong the lifespan by life expectancy by 3 months. Just 3 months, and it's a costly medication.
Then okay, what sort of names are given other than Creutzfeldt Jakob or whatever? They here in the Venomona the variants in.
So, variants of disease, ALS.
Yeah,
is the main
yeah.
one. But
That's the
then
main
there
one
are-
is amyotrophic lateral sclerosis.
Lateral sclerosis. Then
Yeah.
there's primary lateral sclerosis, bulbar palsy, pseudobulbar palsy. Those are the 4 main
I can
See,
amyotrophic lateral sclerosis.
primary lateral sclerosis.
Primary lateral sclerosis.
Yes, there's it's mainly upper motor features.
Upper motor, not
In
motor
ALS,
neuron.
there's upper motor and lower motor. In primary lateral sclerosis, it's mainly upper motor. Then there's bulbar palsy and pseudobulbar palsy. But it's more like a spectrum.
Yes.
Patients tend to evolve from one to another.
Alright.
Usually there's bulb onset.
Anyway, yeah, okay. So those are but basic treatment wise, nothing.
It's mainly like multidisciplinary approach, physiotherapy, speech
Okay.
and language therapy.
Okay.
feeding and all that, social services.
Okay, sorry, quickly, what about myasthenia? Anything new?
Not really. They still use the same old prednisolone, azathioprine, MMA.
And then this cholinesterase, another name, then means neostigmine.
They usually use filgrastigmine. Even in Sri Lanka nowadays, we tend to use filgrastigmine.
Very disturbed. Neostigmine was not available till recent times now. And neostigmine does.
Treatment must be helping the patients a lot, which doesn't happen very well in Sri Lanka.
Yes.
Neurology patients.
Something like the quality of care, the multidisciplinary, they tend to do everything before they discharge the patient. They will arrange house modifications, community physiotherapy, carers, sometimes 24-hour carers, sometimes a nursing home facility, everything for the patient. Because a lot of most neurology patients are left with some form of disability. So they need all these.
I don't know what you think about it.
Disability management, what is the level like neurological disability and anyway when you get the disability?
Yeah, one under.
Disabilities and
Depending on that, madam, allowance is there. But if they don't have any injections and all, the district nurse should go to their house and do the injections. And then
They have carers.
carers, depending on the level of care, depend 4 times a day, sometimes to 24.
it's organized government.
NHS.
Yes. Transport is also managed for them. To go to hospital.
Sometimes housing.
Okay.
If they say the house is too full, it works my arthritis.
Yes. There are patients who wait for months just so that therapists arrange all those things, housing, treatments, carers, sometimes looking for a nursing home. Patients wait for months and months.
Something which is not like now.
Yeah, it's being abused.
Abused a lot.
Yeah, it is abused a lot, but people who really need it also do not get it.
Yeah.
But there I feel that it's just sort of like overlooked also sometimes.
Yeah, එහෙම දැන් මේ ඔයාගේ බලපු එක්කෙනාගේ හැටියට මම ලියපු වෙලාද නැත්ද කියන ප්‍රශ්නෙට
Sometimes therapists won't allow us to discharge the patient. Patient was like that before coming to the hospital, but they wouldn't allow us to discharge. Same patient.
එහෙනම් ඉතින් අපට ගෙන්න
can't
ගන්න
walk like that.
ඉතින් අපට
Can't walk properly.
They talk
ඒ
about
කරන කියන්නේ
disability.
ඩ්‍රාෆ්ට් එකේ ගොඩක් මේවා හිතෙනවනේ යා කියනවා නෙමෙයි ඒක
Patient doesn't like the lecture about patient for some.
මදුන්ගේ හරියට හරි යාට
Yes.
ඒ මොකද එයා අලුතෙන් ඉම්ප්‍රූව් කරනවා මගේ කරෙක්ෂන්ස් ටික දාලා
Yes, kind of situation. There are
ඉන්නේ
wheelchair that
මම ඉන්නේ ඕගොල්ලෝ ඒක මේ ෆැමිලි මම දෙකකින්ම දෙන්නේ
in some
දැන් මාස 3ක් තියාගෙන ඉඳලා
while he was admitted to the hospital. And then they were charged about 4,000 per day for the several days that he was in the hospital. Like that. And so they didn't care all about disability. And then for when patients with disabilities at the hospital, they anyway have a private caregiver. And the private caregiver would charge about 4,000 to 5,000 per day. And if they are in hospital for that long, about 50, 60, whatever thousand rupees, they have all managed. So there are such a lot of problems, transport issues.
දාලා
In the hospital, of course.
ඉස්සරහ දිනවනේ යාදී චෙක් කරලා ඉතිරි
We have to pay for all those things also.
හරි මම දෙකින්වත් එවන්න බලන්න
The change and the attitude and the culture about these things.
ඒ මොකද මම ඒව නැති ඩොක්ටර්ස්මන්ට් බලලා තේරුමක් නැහැ මම වෙලාවේ හරි
It's not just but the overall management is a lot.
Population with services, I think.
Yeah.
We do a lot. Their standards are completely different.
Also the attitude of the staff, especially the attendants, laborers, the category of staff and support staff. How they look at patients.
Team look at it with collaboration. Content services also, I agree, they should be, but nevertheless,
Hi.
the services.
Thank you for the presentation, very study, right?